I'm Nadim Asker from Surgery Resident. We are so grateful for having this opportunity in the health amidst this pandemic situation, so this event can be held today.
And today we both are wearing this beautiful outfit, which is called Batik.
And the reason is because today is
National Batik Day.
2nd of October.
Yeah. And before we start, allow us to welcome the list of attendees that have or will be joining us today. The first one would be
the Honorable Dean of Faculty of Medicine, Universitas 11 Maret, Prof. Reviono.
And then the head of the surgery department, Dr. Suwardi, pediatric surgeon consultant. And then our panelists, we have Dr. Priyan Wasita, MD, PhD from the pathology anatomy. And then Dr. Rahmi Fauziah Rahayu, MD, neuroradiologist. And our moderator, Dr. Mutmainah. And of course, all of the participants
that have attended this Zoom meeting today.
And not forget that we would like to express our gratitude to our distinguished speakers that have coming to us today and sharing this priceless time and expertise regarding the management of thyroid nodules, which are...
The first one will be Dr. Cristanto Yuliarsa, MD, PhD, the oncologist surgeon consultant from Universitas 11 Maret.
And Prof. Jung Won Baek, MD, PhD, the professors in radiology department, Ulsan College of Medicine, Asan Medical Center, South Korea.
So, before we head into the main event, please allow us to run a bit the agenda of today.
The first one would be singing the national anthem, Indonesia Raya, continued by the Mars UNS.
And then the second one will be the opening remarks from our honorable attendees.
And we'll be watching together the video profile of UNS.
And then we have the photo session as well.
Before then, coming to the main event, which is the scientific sessions, and then
the closing remarks.
And then the closing.
So before we heading to the first stage, we would like to ask everyone, the attendees, the speaker, and everyone to join us with praying together.
Praying, start. Okay, now coming to the first session, which would be singing the national anthem together, continued by Mars UNS. For the Indonesia Raya, please come along. Yep.
Okay.
First minutes. Universitas 11 Okay, now coming to the second session, which be the opening remarks. The first speech would be delivered by
Head of our department surgery, Dr. Swati MD, pediatric surgeon. Time and place is yours.
Para pembicara, panelis, moderator, dan seluruh peserta webinar. Salam sehat serta syukur bagi kita semua sehingga dapat berkumpul dalam acara webinar internasional ini. Suatu kehormatan bagi saya untuk menyambut Anda semua dalam kuliah tamu internasional yang membawa kita untuk selalu update dan merefresh masalah-masalah kesehatan, khususnya dalam hal ini yang akan dibahas adalah pengelolaan atau manajemen penyakit nodul tiroid. Seperti kita ketahui, penyakit nodul tiroid ini sering kita temui dalam praktek kita semua, baik dokter umum, residen, hingga para spesialis bedah nantinya. Maka dari itu, topik ini kami hadirkan dan dipresentasikan oleh pembicara-pembicara yang sudah sangat ahli dalam bidang ini. Tanpa panjang kata lagi, saya ucapkan terima kasih atas kesediaan dan waktu kepada para pembicara yang kami undang, yaitu pertama Profesor Yang Hwan Baek dari Universitas Ulsan Korea Selatan. Yang kedua Dr. Kristianto Yuliarsa, konsultan onkologi dari Universitas 11 Maret Indonesia. Semoga dengan adanya webinar ini dapat bermanfaat dan mendorong transfer pengetahuan, teknologi, serta menginisiasi kolaborasi lebih lanjut antar institusi maupun negara yang membawa manfaat bagi masyarakat dan bangsa. Akhir kata, saya ucapkan terima kasih kepada para pembicara yang terhormat, para panelis, moderator, panitia, dan seluruh peserta webinar. Selamat menikmati kuliahnya. Terima kasih. Selamat.
Thank you, Dr. Swati, for the speech. Then we move on to the second opening remarks.
It would be delivered by our Dean, the Faculty of Medicine, Universitas 11 Maret Surakarta, Professor Dr. Reviono, Pulmonologist Consultant. Please, time is yours.
Okay. Thank you for Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good morning, the distinguished speakers and guests, ladies and gentlemen. First of all, it is a very great pleasure for me to welcome all of you. Today is Batik Day in Indonesia. While wearing batik, we join the webinar here in this international webinar held by Universitas 11 Maret World Class University in collaboration with University of Ulsan College of Medicine, Asan Medical Center, Seoul, South Korea, with the title Management of Thyroid Nodule. I'm Reviono as the Dean of Medical Faculty Universitas 11 Maret. I'm feeling grateful for this occasion. Thank you for Professor Yang Hwan Baek, MD PhD. Good morning. And also Dr. Kristianto Yuliarsa, PhD, as speakers, Dr. Ma'inah, neuroscience, as moderator, Dr. Brian Warsisto, PhD, and Dr. Rahmi Fauziah, as panelists who have supported this program, and to all the participants who have enrolled for today. As clinician and researcher, we shall always seek for the better and the best. Importantly, in diagnostic and therapeutic aspects. This program is being held to understand current management of thyroid nodule, which is a common finding in our population. Radiofrequency ablation for thyroid management is a breakthrough. It is non-surgical and minimal invasive procedure. And currently, it's widely used around the world. And but here in Indonesia, there is still some limitation. In the near future, we hope that this modality will be applied more often because of its disadvantage, because of its advantages and lower morbidity risk. With this pandemic, everything seems tougher, but there is always silver lining in the cloud. Amidst the COVID-19, where traveling is still something pretty hard to do or restricted in some ways, we get to connect more through online connection, which give us so many opportunities to adapt and learn. One of the advantages, we get to invite the expert, in this case, Professor Yang Hwan Baek from South Korea, to share his experience and knowledge for all of us in this special occasion. We hope that after this pandemic is over, we get to meet for Professor Baek in person and hope that this collaboration will always go on and drive us to improve more and more. Okay, then I won't take along because I think all attendees already grave on this first topic. Thank you for your attention. Let's grow together for better Indonesia, the greater good for the patients, and explore more in the name of science. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Prof. Refi, for the inspiring speech.
And we were informed that Prof. Jung Hwan Baek has joined us on the meeting today, so that we want to welcome him in person. For Prof. Baek, 안녕하십니까, 교수님. Then here comes the photo sessions.
We would like to ask for our speaker panelists and attendees to open the camera, and then we have the photo session together.
So for Dr. Yarsa, for Dr. Brian, Dr. Rahmi, Dr. Mutmainah, and then for Prof. Jung Hwan Baek and Dr. Yarsa, can we check the camera on so that we can capture us all?
1, 2, 3. Then the next one.
The next page
1,
would be 2, 3. Click. Okay.
Finally, the one we have all been waiting for,
which is time for the scientific sessions that will be hosted by our very beautiful moderator, which is Dr. Mutmainah.
She's one of our lecturer in the anatomy department, Universitas 11 Maret, and
which is also a PhD candidate in University of Melbourne. For Dr. Ina, time is yours.
Thank you. Hello, everyone. Thank you very much for joining us today. And it is such a pleasure for me to be here, to be the moderator for this international lecture entitled Management of Thyroid Nodule. So this lecture is scheduled to last for about 2 hours and 15 minutes. And we will have 2 speakers today, and each of them will speak for about 45 minutes. And then at the end of the second lecture, we'll have another 45 minutes of discussion sessions. So before I introduce the speakers, let me cover some housekeeping topics first. Give me a second. So, okay. So to make this lecture run smoothly without any interruptions, please turn off your microphone during the whole sessions. And of course, questions are most welcome. If you have any questions, you can submit your questions in the chat box throughout the session. And if you are not happy to type it and you want to say it directly instead, you can do so by raising your hand during the discussion sessions. But please remember, you can only speak after the moderator allows you to speak. And then for the Q&A flow, we will first have the participants to ask the questions first, and then we'll give the opportunity to the panelists, and we'll go back to go through the questions from the participants again. And please be aware that this lecture is being recorded. And we also do the live streaming through YouTube live streaming at Bedah Solo channel, as well as Instagram Live. So if you know anyone who is interested to join, but they don't have access to the Zoom meeting, please feel free to pass this information to them so that they can enjoy this lecture through Bedah Solo channel, YouTube live streaming, and also Instagram Live at PPDS Bedah FK UNS. All right, so moving on to the next, I think I'll introduce the speaker for today's lecture. So we will have two speakers for today's lecture. The first one is Professor Young Han Baek from Seoul, South Korea, and the other one is Dr. Kristanto Yuliarsa from Solo, Indonesia. So Prof. Baek will be talking about radio frequency ablation as current management for thyroid nodules. And Dr. Yarsa will be talking about the rise of radio frequency ablation for thyroid management in COVID-19 pandemics. So the first session is going to be a presentation from Dr. Yarsa. Let me give a brief introduction about his profile. So Dr. Yarsa finished his medical degree at Universitas 11 Maret, and then he continued his study to be a surgeon and an oncologist. He's also finished his PhD at Universitas Gadjah Mada, and as you can see here, he's been very updated, and he continued to upgrade his skills by doing some trainings either in Indonesia or overseas. So he's the expert in the oncology surgery. Despite being very young, I would say, Dr. Yarsa has been appointed as the head of general surgery training program here at the Faculty of Medicine, Universitas 11 Maret. So one thing I would say about Dr. Yarsa is he's a great surgeon. He's young and talented. And without further ado, I would like to give the opportunity to Dr. Yarsa to start his presentation. Dr. Yarsa, you have 45 minutes from now. And then, yeah, all is yours. So one thing I would say about Dr. Yarsa is he's a great surgeon. He's young and talented. And without further ado, I would like to give the opportunity to Dr. Yarsa to start his presentation. Dr. Yarsa, you have 45 minutes from now. And then, yeah, all is yours.
Medical Center to join this meeting, and then also thank you for my team who helped me to help this ceremony. Okay, I want to share my slide this morning. My title of my speech this morning is Rise of RFT for Thyroid Management in Pandemic Setting. So the thyroid epidemiology, the worldwide, the prevalence of thyroid is about 50%. We can find in 5,000 in every 100,000 of population. And then usually the nodule found in women is about 5%, and then found in men is about 1%. Some of the patients can find the nodule with the palpation as well detection by ultrasound in routine examination. And then the account for the patient who got the nodule from the palpation is about 2,000 until 6,000 or 2 until 6%. And then the person who got the nodule from the ultrasound examination is about 20% until 35%. Okay, now how we can diagnose the thyroid nodules? The first thing that after we encounter the patient with thyroid nodules, we have to perform imaging procedure. That we can perform the ultrasound, and the result will come out in thyroids. We have 5 thyroids from thyroid 1 until thyroid 5. If the result says there is a benign pattern, so we don't have to perform another examination like FNA. If the thyroid said that there is a low suspicious or very low suspicious pattern, so you have to send to the FNA. If the tumor is reached about 2 centimeter or 1.5 centimeter, and then if the tumor is high suspicious pattern or intermediate suspicious pattern, so we have to send for the FNA examination. And then after that, we have a cytology system for the describe of the result of cytology. The pathology system, we have the score from 1 until 6. If the score is 6, so it's malignant, so we have to perform a surgery. If the score is benign or non-diagnostic, so we have to perform no surgery. But if the conclusion of the result said there is no conclusion or there is any doubt, so we can perform another FNA, or some patient we can perform a core nodule biopsy. In United States, we can send this patient to another examination like immunohistochemistry examination, that they have 8 panel of immunohistochemistry. But unfortunately, in Indonesia, we don't have this kind of laboratory, so we can send this patient to the another procedure, for example, like operative diagnosis. For the operative diagnosis, we can do the smolopectomy, and then if the result is malignant, so we can consider for the total thyroidectomy. Another protocol that we follow in our center, there is a thyroid radiofrequency ablation guideline. Is published by Korean Society of Thyroid Radiology. We can perform 2 FNA for 1 nodule to make sure whether the tumor is benign or malignant. Otherwise, we can perform the core needle biopsy. But if the single FNA with the imaging result is highly specific for benign, is sufficient. And then this diagnosis is benign at least with 1 ultrasound guided FNA or with core needle biopsy in AFDN. So in our center, we also perform a core needle biopsy for the thyroid. The first that we have to find the target that we want to biopsy, and then after that we insert the needle into the target. After we get the target, and then we can on the biopsy. So the tissue is quite big because we use the 16 gauge needle with semi-automatic. The first that we have to find the target that we want to. Okay, I think that's enough for pathology examination. So we jump to another slide. The needle into the target. In our center, how we manage the thyroid nodule, and then we have many of available techniques. The first thing that we usually perform is conventional open thyroidectomy. It's already described by Albucasis in 952 AD, and then the modern thyroidectomy by Halsted in 1850. We still perform that kind of surgery, and then the other endoscopic thyroidectomy, since described by Mikuli in 1990. In our center, we start in 2012. The other is RFA and ethanol ablation, after described in 1998. In our center, start in 2019. How about the robotic thyroidectomy? The robotic thyroidectomy is very expensive surgery, and then with specific have a specific equipment. So because in our country we cannot afford it, so we cannot perform this kind of surgery in our center. How we can perform the open thyroid surgery in our center? Usually, patients have to put in general anesthesia, and then patient have to stay admitted to the hospital about 2 until 3 days. 1 day prior the surgery, and then 2 days after the surgery. We perform the surgery in operating room, and we have 6 person in the team to perform the open surgery. The first that we have operator. The other we have 2 assistants and 1 instrument. The other we have those circulating nurse, and we have anesthesiologist as well. From the open surgery, there is many technique development. In our center, we can perform a subplasma that we preserve the anterior jugular vein. So we leave the fascia. That there is a possibility that we have to cut the strap muscle. The other technique is subfascia, that we cut the anterior jugular vein and then we raise the fascia. So this is less possibility to cut the muscle. And then we have meds. Also, we have a lateral approach that usually performed in Vietnam. In the open surgery, there is many technique development. In our center, we can perform. Okay, now what about the complication of the open thyroid surgery? Usually, they complain about cosmetic is about 3% of the patient complain about the scar. But injury and recurrent laryngeal nerve in our center is very low, about 1%, and then repeating is about 1%. Injury of superior laryngeal nerve is also very rare, hypothyroidism, and then hypothyroidism, thyrotoxicosis, and Horner syndrome. We never face this kind of complication. Okay, now what about the complication? Okay, the result of the open surgery. Some of the patients have a very light scar, so it's very satisfying for the patient. And then for this lady, she has a keloid in front of her neck, and then the other is not really good. So the problem in open surgery is the scar. In the area of minimal invasive surgery, it also can be performed for thyroid management. The minimal invasive video assisted thyroidectomy, or the called MIVAT, was introduced the first time by Nicoli et al. In the 1990. Usually, some other described as remote incision for thyroid surgery. But in 2002, Kitano et al. Already performed a total endoscopic thyroidectomy. After him, there is so many modification. for minimal invasive thyroid surgery like ABBA, retroauricular, and transoral endoscopic thyroid surgery. In our center, we also perform the endoscopic thyroid surgery. We use technique transaxillary technique, and for the surgery, we're using general anesthesia, and then we have to put the patient into the operating room. The patient have to stay in the hospital 1 day prior to the surgery, and then after that 1 day after the surgery. This is the long procedure that we can perform. The fastest procedure that we never perform is about 2 hours, and then the longest is about 4.5 hours. And then it can be performed for malignant and benign. We can take out the tumor, it's about 5 centimeter and less. In this procedure, we have 5% in team. We have operator, and then we have camera nurse, we have instrument nurse, as well as circulator nurse and anesthesiologist. This is the long procedure that we can perform, the fastest procedure that we never. In the endoscopic thyroid surgery, the operative complication is very rare, but the pneumohypoderm is very common. Usually it stays about 24 hours, and then it resolves after the second day. The complication like injury of the recurrent laryngeal nerve is very rare. In our center, we never face that kind of complication. But in my hand, I have one patient with laceration of external jugular vein, and then we made it by clip. After that, the bleeding is stopped, and then the patient never complained about the clip or about the bleeding. So I think it's well managed, and then the complication is very minimal. The complication like the day before endoscopic thyroid in Indonesia, the number is escalating, and then many of center perform this kind of surgery, and then they start in 2012. We can perform it with transaxillary, and then Jakarta perform with two technique, transaxillary and retroauricular. In our center in Solo City, we perform about 35 cases, and then we use the transaxillary. For the thyroid ablation, in our center start in 2019. The RFL ablation that we can perform with RFE, laser or microwave. The RFA, the first described by Sovieti in 1998, and then Profek in 2005. And laser described by Pasela in 2004. The microwave, recently they use microwave by kids in 2015. So how we perform the RFL ablation in our center, the procedure is less invasive because we only use the probe. It's like a small needle with centimeter in length, and we can perform in benign and malignant tumor. We can perform in tumor with the diameter for the more than 5 centimeter. In this patient, we don't have to use the general anesthesia. It's a weak patient, and then we can perform in outpatient department. Patient can discharge after the procedure. Maybe they have to wait 30 minutes, and then they can leave hospital. This procedure is also short. This short procedure is about 30 until 60 minutes with the preparation. We have very minimal team for this procedure. We only have 2 persons for operator, and then 1 for the assistant. In this patient, we don't have For the anesthesia, we don't have to perform general anesthesia. We only use the lidocaine and then we inject a tranexamic. We go through the capsule of the thyroid and then we inject amount of lidocaine. So if there is a layer between the thyroid and then the capsule, so it means that the local anesthesia already done. Okay, for the complication of RFA, it's very minimal. In our center, we got only one patient. The complication, the patient, she complained about the change of the voice, it's like hoarseness. And then after patient see me after 2 weeks, and then the patient said that this complication is resolved after 10 days without any intervention because we don't give any specific medication for this complication. And about pain, maybe the patient experienced about pain in 3 days and well managed with the painkiller. We have no infection and the good thing that we have no keloid or we have no bad scar. You can see this lady is very satisfied because the tumor is big and then it's shrinking after 6 months. It's also this ladies, they feel that the tumor shrinking after 6 months. Okay, another procedure that usually we perform in our center is ethanol ablation. Ethanol ablation is very simple. It's the procedure from a weak patient. It's very effective from the thyroid cyst. Usually, we only put the local anesthesia and patient still awake. We can discharge the patient after the procedure. And then it's very short procedure because we have to suck the liquid from the cyst. After that, we can replace with the ethanol inside the cyst and then we leave the ethanol about 20 until 30 minutes. After that, after we take out every of ethanol, so patient can go home, can discharge from the hospital. The result is also very good. The complication is very rare. Like this patient, he feel that the tumor is missing just after the procedure, and that patient is very happy. But unfortunately, that in the worldwide we have a COVID-19 pandemic that started in China, in Wuhan, and it came to Indonesia in March 2020. In Indonesia, we have 2 waves. In the first wave, that we only have a few cases and then a few escalating. But in the second wave, the case is very escalating, and Indonesia now is number 13. With the number of cases is 4 million and more. And then the problem is Indonesia, we have to get the testing PCR is still costly, and then time for PCR result, we have to wait about the first 24 hours. If the center have already the machine for the PCR testing, so they can get the result in the 24 hours. But if the center of the area and the zone, they don't have a PCR machine for testing, so they have to send to another center. So they have to wait about 3 days until 24 hours. If we want to use the rapid test, at the time we found that the rapid test accuracy is less than 70%. So it can jeopardize the doctor and the patient. And then we found that we have overwhelming health system. Some center we have lack of oxygen. because we have to take care of many COVID patients. Also, we have a high bed occupation rate. Also, lack of health workers because many of health workers they have to take care of COVID patient. If we want to use the rapid test, because Indonesia is an archipelago country, so we have a specific system. In Indonesia, we have a zonation and 4 level of lockdown to encounter the COVID spreading. The first step, if we go live in a green zone of level 1, so we have normal activity and then we can perform any kind of surgery. If we live in yellow zone, we perform the lockdown level 2. So this is the 50% of the procedure of activity of people. And then maybe in hospital, we still can perform in every procedure. Within orange zone, for instance, we have a lockdown in level 3. So we can only perform the urgent case. But in the red zone, or we can say that level 4 lockdown, we can only perform emergency case. So in this COVID pandemic, COVID-19 is an unpredictable disease, and then it will spread very fast. Many patients infected without sign, and we have to consider testing in every patient. That it means it's very costly. The sensitivity rapid test it's still low, and then how long we can use the PCR, for example, that the patient if already testing PCR today and then they have to get a procedure surgery for another next day, so the patient have to get another PCR testing. And this is many questions of patient that usually ask to the doctor. The patient asks how long the patient have to wait for the procedure, because they feel that even though that the tumor is benign and then if the tumor is getting bigger, so patient get panic and stress, so they are seek for help, and then they ask many kind of question. The other is, can we perform the procedure in the pandemic, maybe in some lower level than level 4? And they also ask, do we have to wait pandemic over? And then the most devastating pandemic question is, when the pandemic is over? This question that I cannot answer until now. To answer the many of patient question, so we have to know about the classification of the procedure in this COVID setting, in this pandemic setting. There is 3 classification, A, B, and C. In the A classification, we can only perform the life-threatening procedure, like maybe bleeding, and then a trouble with airway compromise, and then if the patient delay on the procedure, and then it will be life-threatening. In category B, we have B1, B2, and B3. This usually, if we not do the procedure immediately, so the prognosis will be decreased, and then it will jeopardize the patient. So maybe some of patient with cancer or some of patient with the thyroid tumor, we can put in the B category. So another is category C. Usually in category C, we don't have any trouble. Usually it's on the cosmetic, so we can wait till the pandemic over. In category B, we have B1, B2, and B3. In the thyroid setting, the category A, usually if we encounter the patient with life-threatening, like severely symptom like grief, and cannot be controlled medically. And then if there is a goiter causing a compromise, the other is thyroid cancer that imminently treating in life. Also, we can perform open biopsy to confirm the suspect diagnosis of anaplastic thyroid carcinoma that we already know anaplastic thyroid carcinoma is the worst prognosis of all of the thyroid cancer. And the other, we have a thyroid abscess that we have to perform without a delay. The other is thyroid management B. Usually, we can perform in malignant aggressive thyroid cancer, as well as metastatic thyroid cancer. We can perform also in large malignant tumor and suspect malignant nodule Bethesda 4, and then need to perform the procedure. But if the tumor have a benign nodule, and then the nodule is getting larger, and then patient get distressed, and patient seek for help, and then usually they beg to the doctor to perform the procedure. So in our center, usually we put in the management of B. The management of C, usually that the patient have benign nodule without any complaint. So the tumor, the tumor do not getting bigger, and then there is complaint is only cosmetic problem. So before we perform the procedure, so we also have to describe the list of evidence. If we perform the RFA, so it means that the operator have to sit close to the patient mouth and nose for the period of time, maybe 30 minutes until 60 minutes. And then if we perform the open thyroid, usually every of team, they exposed by blood. And then the other procedure like endoscopy, thyroid, usually we believe that the gas evaporation is contagious if patient have infection with the COVID-19. So the next question, if we can do the thyroid procedure independently, how do we perform thyroid procedure independently? The first step to perform the procedure in thyroid, we have to follow the protocol. The first step, we have to reduce the team number of surgery. And then the other, we have to reduce the elective surgery that don't have a significant complaint, like only cosmetic complaint maybe. And then we also have to reduce the length of surgery. We know that the longer we perform the surgery, the longer we stay inside the operating room, and then the higher the risk that we can get. And then we have to reduce bed occupation rate, reducing the use of oxygen. We also have to test the COVID-19 post time of surgery. If the patient have already tested yesterday and then this afternoon, we have to perform a procedure. So the patient have to get another test in this morning. In endoscopic aerosol generating elective surgery should be postponed because we believe the aerosol is contagious for the operating team. We use the maximal protection procedure like N95 for all personnel. If we have to perform the endoscopic surgery, and then we have to use the smoke evacuator. Open thyroid surgery in pandemic, we also perform if the patient have sign of malignancy, and then we cannot delay the surgery. We have to reduce the member of team. Usually we reduce one of the assistant, and still the operator anesthesiologist, one secretary nurse, and one instrument nurse. And then we can only reduce one person in this surgery. And then we put the N95 for the protection in all team. We cannot reduce the length of surgery because in open surgery of thyroid, we have a specific safety procedure. We still use general anesthesia, and then we have to see about the bed occupancy, because if the bed occupancy is high, so we have to postpone the surgery. And then we also see the oxygen stock, where the oxygen stock is minimal, so maybe we have to postpone the surgery. And then some of center, they lack of team, and then the lack of nurse and health worker, and we have to reduce the more blood exposure. So in endoscopic thyroid trick in pandemic, usually we not suggest to perform this kind of procedure in the pandemic, but if the patient need or you really need to perform this surgery, so you have to get a modification. The first step, you reduce the number of pull of instrument. You know, every time you pull the instrument and then you release the gas, that believe the gas is contagious and it can jeopardize the operator and the team. We can use the filter for gas inspirator and gas section. Everybody in that room put on the N95 mask, and then we perform the procedure quickly. It will be very hot, and for this kind of surgery, we produce less haze, and then we cannot release the gas to the air. Before the procedure is done and finished, you have to suck every gas, and then you leave the area without any gas. So, and the endoscopic thyroid surgery in pandemic, if you try that, if you try and you see that we cannot reduce the length of surgery, also that we cannot reduce the number of team, so we still have to perform with 5%, and then we still have to get a general anesthesia. The procedure also depend on bed occupation rate, and then depend on oxygen stock, and usually you have to get a full 5% in team. If you cannot, if you can do another procedure, so I think the endoscopy surgery should be postponed. Okay, the other procedure that we can perform to manage the thyroid nodule, we still have an RFA. So how we can perform the RFA in pandemic setting? Actually, this procedure we no need modification because we already have minimal member of team. We only got the operator and then got the assistant. And then we have to cover our face and our mouth. Also, we have to cover the patient mouth. If usually you perform in 45 watts, and recently we perform in 50 watts to shorten the time of the procedure. You got a less talking with the patient, and then if you need it, you can use negative room if available in the operating room. So this procedure is a weak patient. We perform in the operating room that have a negative pressure. So if we discuss about the open surgery, endoscopic and RFA procedure, even though that there is a lack of evidence that aerosol from endoscopy, I think the endoscopic is not recommended in this pandemic setting because the procedure is very long. You have to stay in the operating room about 3 hours. And then even though that some study say that laparoscopy is better versus open, because we follow safety procedure, that will be minimal blood exposure compared to open surgery. So if we discuss open surgery, endoscopy, and RFA procedure, if we make table and if we make table of comparison of the technique, we combine the open and endoscopy and RFA, that we can see in the open surgery, we got a mass of blood exposure for the patient, and endoscopy we have minimal. In RFA and ethanol ablation, we got very minimal blood exposure. From a size, in open we can perform in any size. In RFA, we also perform in any size. And in the pathology, in open we can do in every pathological. In RFA, we only perform in benign and low-risk papillary thyroid carcinoma. The number of them, if you perform the open surgery, so you have to stay in the room with 6 persons. But if you perform the RFA, you only have to stay with 2 persons in this procedure room. The time of procedure, the average, maybe you have to spend 90 minutes in that room. But in RFA, you can stay and perform the procedure in 30 minutes, maybe 60 minutes with the preparation. The complication in open surgery is about 2%, and then RFA is very minimal. Can say 1 or 0%. The preparation is very fast in RFA, and then in RFA we no need of general anesthesia, and then the patient no need to admit to the hospital. In RFA, we don't need the oxygen for the specific procedure, and then the type of care in RFA is outpatient department, and then in open surgery is inpatient department. So we already performed RFA in pandemic setting, and then we succeed to perform many of cases. There is no confirmed infection after the procedure, and then no operator or assistant confirmed infection after the procedure. So the conclusion from me is we can perform the thyroid procedure in the pandemic setting. RFA is the safe procedure in the pandemic setting, and I can see it's the best choice in the pandemic setting. The care must be taken to patient and health worker for the safety. Okay, thank you for my speech. And if there is a question, you can type to the message. Then I give back my time to the organizing committee. Assalamualaikum warahmatullahi wabarakatuh. So the conclusion from me is we can perform the thyroid procedure in the pandemic.
All right. Thank you very much, Dr. Yarsa, for that very great talk. You finished just in time, and we really appreciate that. And now we've come to what we've been waiting for. It's the session for the keynote speaker, Professor Young Han Beck. So let me just introduce you briefly, and I'll show you the profile. Okay, so for this session, we'll have Professor Young Han Beck, who will be presenting about radio frequency ablation as current management of thyroid nodules. So he is, as you can see here, he is a professor in radiology, Department of Radiology and Research Institute of Radiology. He's been working at Asan Medical Center, and his specialty is in thyroid gland, head and neck radiology, as well as radio frequency ablation. Also, you can see here that he's been one of the top researchers in the world. I can tell you that with an age index of more than 50, so he's got 53 for age index, and he has more than 300 papers, and his work has been cited by more than 9,000 papers. I would say that he is really the expert in the topics that we are talking about in this lecture today. So without further ado, we will let Professor Beck to just present his lecture today. Professor Beck, all is yours.
Thank you for your kind introduction. My name is Jong-Han Baek from Assam Medical Center in Seoul, Korea. It is my great honor and pleasure to I'm sorry. Sorry, there is some minor technical problem for me. Can you see the slide clearly?
Yep.
Thank you.
It's good.
It is my great honor and pleasure to discuss thyroid RF ablation in this wonderful conference. Slima Xiang. My name is Jong-Han Baek from Assam Medical Center. I'm a radiologist. And this is my conflict of interest. This picture is our thyroid team in Assam Medical Center. Our team always discuss and decide our patient under the multidisciplinary approach. This picture is our thyroid team, Assam Medical Center in radiology department. Here in our center, we use RF ablation and ethanol ablation for treating benign and malignant thyroid tumors. We treat benign thyroid nodules about 45%, and followed by 40% of patients with recurrent thyroid cancers. In our center, the treatment of recurrent thyroid cancer getting increase and increase. We also treat head and neck tumors in benign cystic regions such as ranula, branchial cleft cyst, lymphangioma. We use ethanol ablation. But in solid tumors, fibromatosis, sometimes recurrent neck cancers, we use RF ablation. We also treat primary thyroid cancer and parathyroid tumors, but the percent is very low. Let me introduce international thyroid RF guidelines. In Korean society, we published 3 times of our guideline in 2009, 2012, and 2017. And this is our last guideline, a revised guideline published in 2018. In 2018, we also published the ethanol ablation guideline. And this year, 2021, we published the first Asian thyroid RF guideline. This guideline was organized by Asian Conference on Tumor Ablation Task Force team. As I introduced, the international guidelines suggest 3 indications for benign thyroid nodules. First one is a patient with a symptomatic problem or cosmetic problem like this, and the patient with a hyper-functioning nodules related to thyrotoxicosis. What about the thyroid cancer? In primary thyroid cancer and recurrent thyroid cancer, the guideline recommend RF ablation in patient with cannot undergo an operation, high surgical risk, or who refuse surgery. Today, let me introduce ethanol and radiofrequency ablation focusing on benign thyroid nodules. As we know, the clinical problem of thyroid nodule is cancer. However, in benign thyroid nodules, treatment is necessary because of cosmetic or pressure symptoms. As we know, surgery is the standard treatment modality for thyroid nodules. However, surgery has several drawbacks: scar, general anesthesia, or other complications. Among them, hypothyroidism, especially permanent hypothyroidism, is one of the major problems in especially young patients. Therefore, there are several non-surgical treatment options. Among them, chemical and thermal ablations are now the main straight of the non-surgical treatment options. Today, I will talk about ethanol and radiofrequency ablation. There are several advantages and disadvantages of radiofrequency ablation compared with the surgery. Radiofrequency requires no admission, no scar, general anesthesia, or hypothyroidism. And the RF ablation is a very simple procedure, less invasive, less painful, less complicated. In addition, rapid recovery after radiofrequency ablation, and then rapid return to daily life. However, compared with the surgery, the treated nodule, ablated nodule, decrease gradually, and some patients show regrowing of undertreated portion. In terms of ethanol ablation, as we know, this is a very famous minimally invasive therapy. It started in 1989, and it achieved a very good result in cystic thyroid nodules. But there are major limitations in solid thyroid nodules because injected ethanol shows uneven distribution inside the solid nodule. Therefore, multiple treatment sessions are necessary for solid thyroid nodule. Let me introduce our technique for ethanol ablation in Assam Medical Center. As we can see here, it's a very huge thyroid nodule inducing neck bulging like this. We use a small amount of lidocaine for ethanol ablation, and then puncture the needle. We usually use a 16 gauge large bore needle for ethanol ablation, and then aspirate the internal content, followed by normal saline irrigation, then injection of ethanol into the cystic space. As you can see, the aspirated fluid like this. As I introduced, ethanol ablation is a very good modality to treat the thyroid nodule, but RF ablation is also very good modality. Which is better? Which is better modality for thyroid nodule? To have an answer for this question, we performed several prospective studies. We divided the thyroid nodules into 3 categories: cystic, predominantly cystic, and solid nodule according to the amount of solid component. In cystic nodules, which is better, ethanol or radiofrequency ablation? Cystic nodule was defined as a cystic component, solid component less than 10%. We performed a prospective randomized trial. This trial was a single institution and single session treatment and non-inferiority study. Non-inferiority margin was 8% in this study. We randomly enrolled 50 patients into 2 modalities. Primary outcome was volume reduction ratio at 6 months. This study was a non-inferiority study. The concept of non-inferiority study is if efficacy of ethanol is non-inferior to RF ablation, less than 8% of volume reduction, ethanol ablation could be a first-line treatment for cystic thyroid nodules because ethanol ablation is a simple and inexpensive treatment modality. Here is our result. What about the volume reduction of ethanol and radiofrequency? Ethanol ablation is not only non-inferior, but also superior, as you can see, to RF ablation. Therefore, ethanol ablation could be a first-line treatment for cystic thyroid nodules. After this study, we treat thyroid cystic nodules only by ethanol ablation. Here is a huge cystic thyroid nodule. 3 months after ethanol ablation, the cystic component decreased like this, and decreased gradually like this, and nearly disappeared at 5-year follow-up. What about the colloid cyst? Colloid cyst is very hard to aspirate, so we use 16 gauge or sometimes 13 gauge of aspiration needle for colloid cyst. This is 1 month after ethanol ablation. This echogenic region is debris, not solid component, debris from a cyst wall. And this debris is gradually decreased during the follow-up period. This is 1.5, and this is a 3-year follow-up result. So I would say colloid cyst is also very effective for ethanol ablation. So I would say in cystic nodules, ethanol ablation should be the first-line treatment. What about the predominantly cystic nodule? Solid component between 10 to 15%. like this. A solid component has some vascularity, or sometimes there is no vascularity. So we also performed randomized trial like this. In this randomized trial, we compared the radiofrequency and ethanol ablation. What about the volume reduction? Which is better? As you can see, radiofrequency achieved better volume reduction than ethanol. However, there is no statistical difference. So we concluded RFA is not superior to ethanol ablation in this study. So ethanol ablation could be a first-line treatment for predominantly cystic thyroid nodules. However, here is a retrospective study and followed by prospective study. In these studies, we found patients with unsatisfactory result after ethanol ablation. Unsatisfactory patient after ethanol ablation was around 30%. This unsatisfactory patient increased significantly when the solid component increased 10 to 20%. So we found solid component is very important for the result of ethanol ablation. These patients were successfully managed by following radiofrequency ablation. Here is a representative case. You can see the neck bulging in this female patient. The patient show solid and cystic nodule like this. In solid component, you can see some vascularity like this. After aspiration of internal blood, and then we inject ethanol. Immediately after ethanol ablation, we can see the solid component is remained with multifocal internal vascularity. 1 month later, the nodule size increased slightly and vascularity still we can see. So we perform additional RF ablation. This is the ultrasound image 1 month after RF ablation. You can see the internal vascularity disappeared completely and the nodule decrease at 18 months after RF ablation like this. What about the cosmetic problem? Before and after ablation is much improved. Another case here, we can see the predominantly cystic thyroid nodule. At 1 month after ethanol ablation, you can see the black line like this. The cystic space is collapsed like this by ethanol, but solid component is still remained. So we applied RF ablation for this solid component. This is 20 months after RF ablation. Volume reduction was 98%, and there is no internal vascularity. So I would say ethanol radiofrequency combination therapy is very effective in this patient. What about this patient? You can see the huge neck bulging like this. The CT scan, thyroid nodule is bulging at the subcutaneous tissue of anterior neck like this. We combined ethanol for some cystic component and the RF ablation for solid component. This is a CT scan 1 year after combination therapy. The thyroid nodule is nearly decreased like this. The transverse scan before and after combination therapy, you can see the neck bulging is completely improved. What about the cosmetic problem? This is a before treatment. This is 1 month after combination therapy. The cosmetic problem is improved like this. What about the 1 year? The neck mass is nearly completely disappeared in this picture. What about solid nodule? This special effort shows radiofrequency ablation achieved much better volume reduction than ethanol ablation. Therefore, almost all guidelines recommend somal ablation rather than ethanol ablation. Therefore, in solid thyroid nodules, we compared two representative somal ablation modalities, radiofrequency and laser ablation. We used two meta-analysis methods. One is pooling, the other is a network meta-analysis. What about the pooling method? The volume reduction, which is better? As we can see, radiofrequency achieved much better volume reduction than laser ablation. We enrolled 12 studies from laser and radiofrequency ablation. The second one is network meta-analysis. And there is no study directly compare the radiofrequency and the laser. Therefore, network meta-analysis compare these two modalities indirectly using other randomized trial. There is two randomized trial comparing control group and radiofrequency ablation group, and 3 studies comparing two modalities. Using these 5 randomized trials, we can compare two modalities indirectly. So also there is one randomized trial comparing single session radiofrequency and dual session, 2 sessions of radiofrequency ablation, and the single session laser and 3 sessions of laser ablation study. Using these 7 randomized trials, we compared these studies indirectly. Here, this table shows the result. Which is number one? Which is number one? As you can see, the 2 sessions of RF ablation is number one. Probable best is 53%. This one. And followed by, which is number 2? Single session radiofrequency ablation, followed by 3 sessions of laser ablation. So I would say RF ablation is better than laser ablation for treating solid thyroid nodules in terms of pooled volume reduction, and network meta-analysis. What about radio frequency and the microwave ablation? This method is very common in China. So let me introduce this large population prospective multicenter study. This study compared radio frequency and microwave ablation. In both groups, more than 600 patients were enrolled. This is a very huge population study. What about the result? After 6 months, the radio frequency achieved better volume reduction than microwave ablation. So this is my result. Final summary. In cystic thyroid nodules, we recommend ethanol ablation. In predominantly cystic nodules, we recommend ethanol ablation first and followed by radiofrequency ablation. In solid thyroid nodules, radiofrequency ablation is better than other thermal ablation method. Let's move on to the procedure. How to ablate thyroid. Here is our guideline. Suggests standard techniques. There is 3 techniques. Parathyroidal lidocaine injection to control pain, and recommend the transseismic approach and moving shot technique. Here you can see the preparation of radiofrequency in our center. The preparation is very simple, like a biopsy. And in our ultrasound room, we prepare the vital monitoring system and oxygen and suction. After sterilization of the skin, as I introduced, we use a small amount of lidocaine for control pain, and then treat the nodule using transseismic approach and moving shot technique. Immediately after ablation, you can see the pinpoint scar in the neck. And this scar is completely disappeared within 1 month. Let me show moving shot technique. This is here. You can see the right thyroid nodule. The electrode approach is done through isthmic area. We call transismic approach method. We treat posterior portion first and then move anteriorly. As you can see, the electrode move continuously like this. Some portion is overlapped, ablation area is overlapped like this. RF ablation is terminated when the nodule changed to echogenically, but we don't treat this area because here is recurrent laryngeal. As time goes, we can treat this area safely. I introduced transseismic approach and moving shot technique in this video clip. Let me introduce ultrasound video clip. As you can see, we treat posterior portion first and then move anteriorly. We don't treat this danger triangle because here is recurrent laryngeal. As you can see, the electrode move continuously. This video is my very initial experience. Let me show another video clip at the end of this lecture. Let me introduce this electrode. Here is a 17 gauge long electrode, commonly using in the liver ablation, hepatoma, or metastatic liver tumors. But this is a modified internally cooled electrode for thyroid. We developed this modified electrode. This thyroid dedicated electrode is short, 7 centimeters in length, for easy control and thin to minimize normal thyroid injury. And we have various sized active tips. I introduced we have various sized active tips. We use these tips according to the status of tumor, and the RF power is totally different according to the active tip size. Please remember this table. So this smallest active tip I use in recurrent thyroid cancer, parathyroid tumor, or PTMC. In 5 millimeter active tip, I prefer to use in second or third RF ablation. And the 7 millimeter active tip, I use less than 3 centimeter benign thyroid nodule. And more than 3 centimeter, I use 1 centimeter active tip. Please remember this table. Pain is most common problem during RF ablation. Sometimes radiating to teeth, ear, chest, shoulder, even back. I have several solutions: reducing RF power, or stop ablation for several seconds. Sometimes I use painkiller. Some institutions use sedation or general anesthesia, but I don't use. This picture shows a perithyroidal lidocaine injection during RF ablation. You can see the insertion of electrode and lidocaine injection needle together. Here, you can see the strap muscle and the thyroid nodule. Between two, we inject lidocaine. We called this area perithyroidal tissue because there is no sensory fiber inside the thyroid gland, but abundant at perithyroidal tissue. That is why we recommend perithyroidal lidocaine injection. After injection of lidocaine, we treat thyroid nodule by RF ablation. We can minimize pain during ablation. Here is ultrasound images before and after radiofrequency ablation. You can see this nodule is a well-treated nodule by RF ablation. As you can see, what about the echogenicity? Decrease, change to hypoechoic. What about the internal vascularity? Disappear. And you can see the size of nodule decrease like this. This is ultrasound feature of a well-treated nodule by RF ablation. The size of nodule is increased in next day because swelling of nodule by heat, but start to decrease at 1 week. We can achieve rapid volume reduction during the first month, and after 1 month, volume reduction is relatively slow. Let me introduce clinical outcome. Here, you can see the solid thyroid nodule. After radiofrequency ablation, the nodule decreased and nearly disappeared. This nodule is decreased and remained as a linear hypoechoic area, and it is completely disappeared at 108 months. Here is a huge 7 centimeter predominantly solid nodule. After radiofrequency ablation, it decreased gradually like this, like this, like this, and remains as a scar-like lesion. What about this patient? This patient shows bilateral huge thyroid nodules. The CT scan shows a solid and cystic thyroid nodule. Therefore, I applied ethanol ablation 2 times for cystic area, but ethanol ablation was not effective. Therefore, we applied RF ablation for this patient. This is the picture before ablation. 6 months, slightly improved. 1 year, much improved. And 1.5, you can see the considerable improvement of neck bulging. Let me introduce the airway compressing goiter. This patient visited our emergency room because of dyspnea. You can see the narrowing of trachea by huge thyroid goiter. As you can see, the tracheogram shows narrowing of trachea. We immediately applied the tracheal stent like this, and then applied radiofrequency ablation for right and left thyroid nodules. You can see the ablation of bilateral thyroid nodules like this, and we removed the stent at 3 months by endoscopy guided. This is the picture before and after radiofrequency ablation, and the tracheal lumen is increased after radiofrequency ablation. So here is long-term result comparing radiofrequency and the radio ablation. Radiofrequency achieved a very excellent long-term result. However, this paper suggested regrowth and long-term follow-up here. Regrowth means recurrence of treated nodule. Recurrence is induced. Usually treat the central portion of the nodule and the remained margin of the nodule. We called under treatment of nodule margin. This nodule, after radiofrequency ablation, the nodule decreased like this. However, what about the margin? It remained. 4 years later, the well-treated center decrease like this, but the margin increase like this. This is marginal regrowth. Marginal.
Perfect. You have 5 minutes more.
Yes, I understand. Yeah. Marginal regrowth is more common in vascular nodule. After radiofrequency ablation, you can see the much decreased vascularity at 1 month, but we can see the regrowing at 3 months. So I treated again. After second ablation, you can see the nearly disappeared vascularity. However, 6 months later, you can see the typical regrowing. So I tried the third ablation. The marginal vessels show regrowing again. So I treated the nodule and the surrounding vessels together. Surrounding vessel, please remember. What about the result? Was very excellent. So we suggested a vascular ablation technique. Vascular ablation technique is very important to control marginal regrowth. In this case, you can see the direct puncture of marginal vein by RF ablation. You can see like this, the bubble inside the marginal vein, and we achieved the excellent result. Let me introduce this vascular nodule. We treated this nodule by venous ablation technique. You can see that the needle directly puncture the marginal vein and then ablate. You can see the filling of marginal vein by echogenic bubble like this. This is a venous staining technique. In terms of complication, the voice problem is most common complication, but the sequelae rate is very low in radiofrequency ablation. So today I introduced how to select RFA or ethanol ablation and standard techniques and venous ablation techniques to minimize marginal regrowth. Thank you for your attention.
Yep. Thank you very much, Prof. Beck. That was a really fantastic talk, and I believe that all of you have enjoyed the lecture as well. And now we've come to the discussion session, but let me just remind you for the, so we'll have several questions which will be discussed in this session. We will have 2 panelists which will help us conduct the discussion today. The first one is Dr. Brian Wasita, MD, PhD. He is an anatomic pathologist who is also a lecturer at the Faculty of Medicine, Universitas 11 Maret. And we also have Dr. Rahmi Fauziah Rahayu, MD, and she's a radiologist at Dr. Muardi Hospital. And for anyone of you who still have a question in mind, but you haven't submitted, please do so by submitting in the chat box, or you can just raise your hand and we'll give you the chance to speak. The other thing I would like to say is we'll have 6 copy vouchers to those selected questions. So please use that opportunity to ask as many questions you want to ask. So for now, we'll go through the questions from the participants first. Yeah. So firstly, I'll read the first question from Dr. Anis Ardi. Yep, Dr. Anis Ardi. Anis Ardi, yep. So I'd like to ask to Professor Beck, when do we do RF or EA or combination of both? And what do we have to do or what we have to consider pre and post RFA or EA? That's the question for Prof. Beck. Please,
do you mean the blood test or other preparation?
So I think she's asking whether what kind of things that we have to consider pre and post the RFA and ethanol ablation, and then can we do the combination of both techniques?
I understand that the question is how to select RF population or ethanol. That's as I introduced, the amount of solid component, solid. You understand? Solid component more than 20%, and especially there is many vessels.
Yeah.
I recommend radio frequency ablation than ethanol.
Yep. I hope that answers your questions, Dr. Anis Adi. And then we also have another interesting questions from Dr. Abi Wicaksono. So he says, good afternoon, my name is Abi. He has several questions. The first one, what would be the main criteria and concern while choosing between RFA or EA for a patient with thyroid nodule?
I don't understand where.
So maybe when, I think he's asking when we should choose RFA or EA.
As I introduced, the solid component is important. Amount of solid component and amount of vessels inside the solid component. That is a main factor to select RF ablation or ethanol ablation.
Okay, and then he's also asking, what is the main complication that will affect the patients after after that procedure based on your experience?
Yeah, first one is voice problem, voice change. That is usually injury of recurrent laryngeal nerve.
Yep. And the third question is, if that patient had previous EA and then it was unsatisfactory, I mean, with that EA, the result was unsatisfactory, does that RFA procedure will affect the outcome of that patient?
Yes, we recommend the RF ablation for unsatisfactory patient after ethanol ablation. RF ablation is very effective.
Okay. And the last questions from Dr. Abi is, do you personally think that EA RFA will change how clinicians treat thyroid nodules in the future?
I'm not sure. Anyone can give answer?
Dr. Yaksa, maybe you have another answer. So he's asking, what do you think personally, whether EA or RFA will change how clinicians might treat thyroid nodules in the future?
Okay, thank you for the question. That I think the RFA and EA is already changed the clinician for the treat the thyroid nodule, because I have already seen this thyroid nodule ablation. It's already performed in Korea, and then the other in Italy, Taiwan, and also in United States. The surgeon over there is already changed from the open surgery, and then after that, several years ago, they changed into endoscopic surgery, and then this year they changed into RFA radio ablation for the thyroid nodules. Thank you.
Right. So we've got another question for Dr. Yasa here from Dr. Ari Setiawan. He's asking how RFA procedure is conducted. Is it only single shoot or should it be repeated? And maybe how many times should we give that shoot if it's not single?
repeat RF population is available in most of the patients without increasing complications. My question is okay.
Yep. And then we have Dr. Daddy here. So how long is the follow-up post RFA procedure? Based on-
I usually follow the treated nodule is completely stable. That means it remains as a scar-like region and unchanged. 2 or 3 years, I stopped the follow.
Yeah. Do you have any other explanation, maybe, Dr. Yasa, for this question? What is your experience? Nope, all good. Okay, so we will have 2 more questions from the participants, and then we'll have we'll give the opportunity to the panelists. So this one is from Rizky Patria. Good morning. I want to ask, what are the requirements of patient who can be treated with RFA? I think, yeah, Dr. Yasa or Prof. Beck, you can maybe answer this one. But yeah, you have, I think you have explained this in the previous questions. One last question before we go to the panelists to ask. So how long does the RFA procedure takes? Does it depend on the size of the thyroid lesions?
Yes. Depends on the thyroid nodule size.
So how long it takes will depend on the size of that nodules, of course.
I usually treat the nodule 20 to 30 minutes. 20 to 30 minutes.
Yeah, so that was a really quick procedure. All right, so for the next opportunity, I will give the panelists a chance to maybe just have a discussion with all the speakers. First, I'll give a chance to Dr. Priya. If you have any questions and you want to make any discussion with Prof. Beck and Dr. Yasa, please, you can do it now. I think you have to, yeah, please let Dr. Brian unmute, so maybe the host can help him so that he can unmute.
Yes, thank you very much. Yes, thank you very much, Dr. Utaina. Yes, Prof.
May I ask a question for Yarsa?
Yes, please, Prof.
Yeah. My question is your experience with RF population. How many cases?
From the 2019, I have already about 25 cases, Prof.
25.
Because we have a pandemic, so in the first wave we not perform at all.
Good. Did you treat only benign thyroid nodules or primary cancer, recurrent cancer? No?
From now that we only treat the benign nodule, and
benign
then for
nodules,
the cancer we all perform this open surgery.
Okay. In our center, recurrent cancer getting increase. In our center.
Yep. So is that
Dr.
all?
Brian, maybe?
Yep. So now I'll give the chance to Dr. Brian.
Thank you very much, Dr. Mutmaina, for the opportunity. Very nice lecture. Thank you very much, Prof. Beck and Dr. Yasa. For Prof. Beck, I would like to ask several questions. I'm a pathologist, so before you perform RFA procedure, do you also need the histopathological results, for example, from FNAB or
core biopsy?
Core biopsy before you performing the RFA, Prof. Beck?
Yarsa?
I think he asked about the diagnosis, Prof. In my center that we perform of FNAB, also the core biopsy, and then if the result is any doubt that we cannot show whether this is benign or malignant, so usually we perform open surgery. But if the clinical sign is benign and then the FNAB is said it's benign, and maybe the Bethesda system is only 3 prescore, so we perform the RFA.
We use a combination of FNA and RF ablation, and sometimes use the BRAP or other ancillary test for the nodule. And we treat Bethesda 2, mainly based Bethesda 2, and sometimes Bethesda 3, or for inpatient with inoperable status.
Okay, thank you, Prof. Another question is, in your experience, is there any different? Is there
I'm sorry, the sound is not clear.
I'm sorry, Prof. I will repeat my question. In your experience, do you have any experience that before the RFA and after the RFA, change in histopathology, for example, before RFA, the RFA interended just 4 or 5.
I'm really sorry, Dr. Brian, but we can't really hear you. So I think you can please keep that question, and I'll give you another chance to ask that question again to Prof. Beck. In the meantime, I think I'll give the opportunity to Dr. Rahmi. So Dr. Rahmi, if you want to ask and start a discussion.
Okay, thank you, Dr. Mutmainah. Thank you, Prof. Beck and Dr. Yarsa. Thank you for the excellent lecture. I am a radiologist from Muardi Hospital, and in our hospital, prevalency of the thyroid nodule is 41 years in 2020 until 2021, about 218 cases. More of than 70% is malignant cancer, malignant nodule. And then we have some imaging modality like ultrasound, CT scan, and MRI. But until now, we don't have experience about the RFA. And I hope the future we can more try RFA or ethanol ablation, combination with collaboration with the Dr. Yarsa from oncology department and Dr. Brian from pathology department. And maybe my question is for the evaluation after we ablation, how what's the imaging get used? Only ultrasound or another like a CT or MR? And then do you have experience about the elastography ultrasound for diagnostic to nodule thyroid? Thank you, Prof.
Thank you for your question. It is very important. We mainly use ultrasound without elastography.
Yes.
And sometimes we use a CT scan in case of intrathoracic goiter. Intrathoracic goiter to check the size change.
Okay.
But after radiofrequency ablation of recurrent cancer, a CT scan is mandatory. Yeah, okay.
Okay. Okay. Thank you, Professor.
You're welcome.
Right. Do you have any more questions, Dr. Rami, for now?
Maybe I will share screen share, yeah. That's the. Bisa ya? You can see.
Yes.
This is our city. This is Central Java, and we are in Solo City. Solo City is the President Jokowi village. We are very famous about the batik, like we use today, and foods and the hospitality or our people here. And this is our university, 11 Maret University. And then this is our hospital, Muardi Government Hospital. And this is the prevalence nodule in our hospital. More of that is malignant nodule. And this is me and Dr. Brian collaboration for guiding to thyroid nodule. And this is the modality that we have in our hospital. And future soon we have a nuclear department to more good diagnostic and therapeutic to the patient for ablation. Maybe this profile from our city and our hospital that we have someday you can visit here, and so we can visit your hospital there in the Korea. Thank you, Professor.
Thank you for your introduction. Thank you.
Yes.
Okay, thank you very much, Dr. Rahmi. That was a very interesting slide. And if you have more questions, we can keep it in the next session. In the meantime, I'll give the opportunity back to Dr. Brian, who still have questions. Please, Dr. Brian.
Thank you very much, Dr. Mutmainah. Thank you, Prof. Beck. I just still have one question, Professor. In your presentation, you mentioned that you also treat RFR in malignant thyroid for about 1%. So what kind of histology type has better response to the RFA? Is there a papillary type, follicular type, medullary type, or anaplastic type? Thank you.
Yes, we treat papillary cancer, small papillary cancer, we call the PTMC, and sometimes we treat inoperable anaplastic cancer.
So about the response, Professor, which is better, have better response to RFA?
Pardon?
Response.
For PTMC, RFA is a very excellent. But in anaplastic cancer, RFA does not work well. Because doubling time of anaplastic cancer is so fast. You understand that doubling time means the growing of
yes.
Okay, thank you very much to all the panelists. We'll go back to you later after we go through the questions from the participants. For now, I think I'll give the opportunity to the participants who have raised hands. So here I can see that, yep, Dr. Muhtar Hanafi has raised hand. So I'll give the chance to Dr. Muhtar Hanafi to speak now. Please, Dr. Muhtar Hanafi.
Thank you, Dr. Ina, for the chance. I would like to ask a question to Prof. Beck. I have 2 points in here. The first question is about the requirements of the nodule. So is there any requirements for the thyroid nodule so that it can be done by radio frequency ablation? That is my first question. And then the second question is that, is there any research, evaluation research regarding about radio frequency ablation, regarding about the recurrency of the thyroid nodules after being radio frequency ablation?
Do you mean the recurrence rate?
Yes.
Recurrent rate is different according to the institution. In our center, about 10% of recurrence rate. And the first question is requirement of RF ablation. I don't catch the requirement.
I mean, is there any requirement for the nodule? For example, the measurement of the nodule, it has to be less than 3 centimeters, for example, or any nodules that we can do the radio frequency ablation.
As I introduced, the Bethesda system is 2 Bethesda category 2 benign nodule, and maybe size is no problem. You can treat large nodule by repeat RF ablation, repeat.
Yeah. Okay. Thank you, Professor.
Thank you.
Thank you, Dr. Murthy, for your questions. Okay, while waiting for other participants who might want to raise hand, I'll go through the question in the chat box again. Just remember, we have 6 GoPay vouchers to any lucky participants today. So if you have any question in mind and you haven't submitted, please do submit it now. Okay, so I've got a question from Dr. Anis here. No, sorry, it's from Dr. Anissa Nurpeti. So the question is, to Professor Beck. Can the RFA procedure be carried out by a radiologist who has undergone formal training? I think the question might be, do we need more advanced training to do the RFA, or once we got the radiologist degree, then we can perform RFA?
In Korea, RF ablation is a very popular treatment method for thyroid nodule. So radiologists initially started this procedure, but now surgeons such as a general surgeon, ENT surgeon, and some endocrinologists also do this procedure. And we Assam Medical Center has a training program for RF ablation. So we recommend at least 10 cases of experience with expert that can enhance the efficacy and the safety of the procedure.
Yep. Okay. So that's at least 10 RFA to be expert. Yep.
With the expert.
Okay. So what about here in Indonesia, Dr. Yasa?
Again, in Indonesia, we don't have official yet for the training of RFA, and then maybe next year after the pandemic is over, will be held
official training for the RFA. I hope.
I know that the endocrinologist, Dr. Hendra is expert in this field in your country. Maybe.
Okay, bro. Maybe.
Yeah,
Well,
so we can please go, Prof. Beck.
why don't you establish your training program for Indonesian doctors?
Okay, bro. Maybe after the pandemic is over.
Yes.
Yeah. I think that is a really great idea because Dr. Yasa, I would say he is among the first who conduct this procedure here. So you are the pioneer, Dr. Yasa. Let's just maybe we can develop this and establish this technique here. All right. So we'll go through the questions from the participants again. From Yutrisa Sasti. So to Prof. Beck, what is the side effects for the patient who received either ethanol ablation or RFA based on your experience? What's the most common side effect?
Most common side effect is maybe pain, but it is not so serious for RF ablation. The serious complication is, as I introduced, voice problem, damage of recurrent laryngeal nerve.
Yeah, but is there any case where the patients then continue to have a serious voice problem, Prof. Beck, or it's just temporary and it will just resolve within days, for example?
Usually temporary. And recurrence rate is much higher during treatment of recurrent cancer. So we developed the management program for nerve damage symptoms, injection of cold water around the damaged nerve. That is very effective to manage the nerve damage symptom.
Yeah, just out of interest, Dr. Yesa. So, so I believe that side effect might be, yeah, we might find that side effect as well here. Do you have any suggestions for the patients? How you explain and what to do if the patients experience that based on your experience?
For patient?
Sorry, I'm asking Dr. Yasa here with his experience with Indonesian patients. Is it also common to have that voice problem? And then what do you usually suggest the patients if that case happen?
I think in my hand, because I have a little experience, so I only perform the RFA for 25 case, and then one of the case that the patient got a hoarseness and then got a change of her voice, and then she realized the day after the procedure, and then I said that you can calm down, and then if you wait maybe until 1 month, the problem will be resolved. And then happily that after the patient see me 2 weeks after the procedure, and then she said that after 10 days my problem is resolved, then I not take any of specific medicine. So no, my voice is already came back as before. So I think it's keep me encouraged to perform another procedure.
Yeah.
Thank you.
Yeah. So I think to all the residents here who might be doing that as well, they can help explain to the patients when you do that. Another question. We've got a question from Dr. Yusuf Nawawi. The first one is, what are the clinical indications to do the ethanol ablation or RFA treatment over surgery? Would you like to answer that, Prof. Beck? I think we've talked about this before, but if you have any more explanation, Dr. Yasa, then
maybe I want to know about the Prof. Beck experience in Korea, because in Indonesia, in our patient usually they afraid of getting an open surgery, so they come to me because they afraid of performing open surgery. But I think in Korea they usually came to Prof. Beck because they already know that the RFA is the most effective to manage the nodule. So what about your opinion, Prof. Beck?
That's a very good question. In my outpatient clinic, I use a shared decision with the patient. I give information about RF ablation and surgery together, and then we discuss which will be better for the patient. Shared decision.
Yes,
Yep.
I think the patient, if you explain to the patient that the patient, it don't have to be admitted to the hospital and then don't have to get a general anesthesia, and especially that we don't have to open the skin and then we don't go through inside thyroid with our hand. So the patient usually will choose the RFA ablation in my center.
So he's also asking, actually, have you ever had any experience or recurrently growing nodules after EA or RFA? Yeah, so Prof. Beck have actually explained the recurrency rate when Dr. Muhtar Hanafi asked questions. But yeah, do you still want to add more, Prof. Beck?
The recurrence rate, as I introduced, recurrence rate is usually 10% in our center, and in case of recurrence, we treat again by RF ablation.
Yep. Another question from Siwi Bagus. Can it be, yeah, this is the same question. Can it be combined? Can you combine EA and RFA? Thank you.
Yes, we can.
The other question, so this is one, the same question. So Dr. Dodi asks the same question, so I'm going to skip this. This one from Monica. Can it be used in cases of malignancy? Yes, I think we can. We have explained about that. And then is there any significant difference in the case of thyroid nodules with TRATs 2 and 4 in the outcome?
I'm not sure. No difference.
Dr. Yarsa, maybe.
Maybe I think the question will be like this. Is there any specific appearance in the ultrasound that have a very good response compared to the others?
I'm not sure.
You're not sure.
Maybe no.
Okay.
Oh, okay. So maybe we'll skip this one. Let's see if we have another question. Dr. Kristanto, you've got a questions from Dr. Lalu Fauzan. If we want to do a surgery, for example, tracheostomy, how long does it take to perform that between the ablation, the RFA, and the surgery?
So usually the tracheostomy is performed under emergency procedure or urgent procedure. So if you have a problem with the airway, so you can perform immediately after the airway is appeared, then you can perform the tracheostomy. But if you perform the RFA ablation radiofrequency ablation to shrinking the tumor, and then you wait. After that, you can perform the tracheostomy. So maybe you have to wait about 1 month until 3 months. And then after the tumor is shrinking, maybe you can perform the tracheostomy. Thank you.
Okay, I hope it answered your questions. So we will go back to the panelists for now. I'm gonna give the opportunity to Dr. Brian and Dr. Rahmi. If you still have things to discuss with Prof. Beck, then I'm happy to give you that chance now.
Yes. In your experience that you ablation ethanol at the RFA and combination with operation procedure is usually true there, Professor?
Pardon, sorry.
Combination from ethanol ablation or RFA and the operation procedure.
I'm sorry. I don't catch your question.
Maybe you repeat again, Dr. Rahmi.
Okay. Do you have experience combination for 3 therapeutic with AO, RFA, and operation procedure?
3 operation and RF
Yes.
population. No.
Oh no.
Okay.
Okay.
No.
Okay. And how about the measurement of the tumor? Is more bigger, more recidive, or only by pathological anatomy finding for the recurrent tumor? Is the measurement of the tumor
I think the question will be like this, Prof. After the tumor is recurrent and then it's came to you, and then do you have to perform another examination like another pathological or another ultrasound? Do we have to make sure that that's still benign or become a malignant?
Yes, it is extremely rare in our center. Extremely rare.
Extremely rare.
Yeah, very rare. Yeah.
Okay.
Because sometimes when we do ultrasound, we can confuse to differentiate it about this is benign or malignant. Usually in the young people and microcalcification, diffuse microcalcification is thyroid 3 or thyroid 4, because Dr. Yarsa always say me, how this thyroid? This.
Yeah, I understand. So at that situation, we do core needle biopsy to verify the pathology. Core needle biopsy is more correct for calcified nodule.
Okay, enough. Thank you.
Thank you.
Thank you, Dr. Rahmi. Dr. Brian, you've got another question?
Thank you very much, Dr. Rumaina. I have a question to Dr. Yarsa. As a clinician, what do you want in the histopathological report before you perform the RFA? Thank you.
So thank you for the question. This is very important question because before I perform a procedure, that the first thing that I want me to show that is it malignant or benign. And then if the result is malignant, so I want to know that what is the kind of malignant, like papillary or follicular. But if we cannot receive that kind of conclusion, so maybe you can give us like a maybe Bethesda score or a clue that we can make a conclusion, and then we can explain to the patient that your tumor is we think the tumor is benign because the conclusion is from the pathological and pathologists and radiologists. They said the data like this. So we found to get the data to explain to the patient whether the tumor is malignant or benign. That's the most important. Thank you.
Thank you very much.
For Dr. Yarsa, do you have a report
Dr. Mutmainah
correlation from radiologist finding and pathological finding? Do you have a report from your patient in your experience?
I have already conduct a study about the thyroid score and then the pathological report, and then until nowadays, the study is still running, and then maybe the result come out next year after we get enough case. So I will share. I will share to you. Thank you.
Okay, thank you.
Thank you very much to both panelists, and we'll go back to the participants' questions for now. We've got another questions from Dr. Teguh Winandar from Department of Surgery. So this is for Professor Beck. After RFA on benign nodules, does the patient still need to use the TSH, thyroid stimulating hormone suppressive medicines? And have you ever used RFA on the patients with malignancy size over PTMC cases? Thank you.
Yes, we tried some PTMC cases, and there has been no recurrence so far. And we don't use thyroid hormone therapy after RF ablation.
So that, I hope that answers your questions, Dr. Teguh. So no hormone replacement therapy. We still have 1 minute for question and answer. So if you still have something to ask, please feel free to raise your hand.
A question. I have one question for Prof. Beck. Prof. Beck, do you still perform RFA in your center in the pandemic setting? Actually, for your people, maybe it's not come from overseas.
Although the Korea pandemic, COVID-19 is not so controlled so far, RF ablation is not affected by this pandemic status. Not affected by, yeah.
So you still receive the patient from overseas? Okay, thank you, Dr. Mutmainah.
Yeah, well, that is really good news that in Korea, in South Korea, we can still perform the RFA despite the current situation. So hopefully we'll be able to do it soon here as well, Dr. Yarsa. So I think we've come to the end of the discussion sessions, and I believe it's been a very useful discussions that we have today. As I have said before, we're going to have 6 copay vouchers to those lucky participants. So I'm going to announce the winner. Okay, so the first one is Dr. Ari Setiawan. And then the second one is Dr. Abi Wicaksono, Dr. Anis Adi, Dr. Mukhtar Hanafi, Dr. Yusuf Nawawi, and the last one is Dr. Teguh Winandar. So congratulations to all the 6 winners. So I would like to say thank you very much to both speakers. Let's give the applause to Dr. Yarsa and Prof. Beck. Thank you very much for your time. We do really hope that we can meet in person sometime. And then as an appreciation, I would like to please, so the committee, please help me to show the certificate for our keynote speaker. This is a certificate of appreciation for Professor Beck, who has spared his time to be with us today. So once again, once
Thank
again,
you.
yeah, it's been really a really nice opportunity to have you here, Prof. Beck, and we do really hope to meet you in person sometimes, hopefully. And lastly, I would like to say thank you to all the participants and to everyone who's been, who have stayed this long, this whole day to enjoy the lecture.
Thank you.
And to
Perfect. Thank you.
Thank you. Terima kasih.
Ya, kamsahamnida.
Terima kasih.
Terima kasih, Professor.
Prof, just for your information, Indonesian, many Indonesians are K-pop lovers.
Oh, really?
Lovers, yes.
Yes.
I would say that maybe more than 70% of the participants here are K-pop lovers and Korean drama lovers.
Okay.
Sarangi.
Sarangi. So we're very happy to have you here, to have someone from Seoul, South Korea here.
Thank
Definitely. You. And maybe the committee can also display the certificate for Dr. Yasa. You have any or no? So this is also to appreciate the efforts from Dr. Yarsa and the team of those. Thank you very much for sharing your knowledge to all the participants, and hopefully, we can do the same lecture in the future with you. Okay, that is the end of this session, and I apologize if I made any mistake during this discussion and during the lecture. And next, I will hand the floor over back to the Master of Ceremony. See you next time. Bye.
Bye.
Thank you, Professor.
Thank you.
Thank you.
Alhamdulillah, Yasudim. Kamsahamnida. And thank you for Dr. Ina for hosting the session.
Yes, it was really interesting and so interactive. So we hope all attendees enjoy the session as well.
Before we come to our last agenda, we hope that we can do another photo sessions so that we can check on each other and we can capture this moment. Can you please Prof back to, okay, stay on the camera, and Dr. Yarsa, and of course all of our panelists.
Yes.
Yep. So that we can take the picture together and we can always memorize today. Oh, dan untuk semua attendees mungkin bisa untuk men-switch on camera, jadi kita bisa meng-capture kebersamaan kita di hari ini. Untuk seluruh pembicara, kemudian untuk panelis kita, kemudian Dr. Ina, kami mohon izin untuk meng-capture untuk Dr. Rahmi dan Dr. Brian. And of course for Prof. Beck, for Beck Yasmin, we want to take the picture together. Can I count on 3 and then we are going to capture together. 1, 2, 3. With the biggest smile.
Okay.
For the next page, I think we have a lot of participants here. So
yes.
Really,
so we will come to our last
event,
which is closing remarks from
Dr. Eti. She is the head of the medical study program, Universitas 11 Maret Surakarta, and the time is yours for Dr. Eti.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. I'd like to start by thanking Professor Hyung Wan Baik and also Dr. Yarsa for your willingness to share your expertise in this event. It has been such an honor for us to have you here, and we do hope that this guest lecture will mark the start of future collaboration between Faculty of Medicine Universitas 11 Maret and Ulsan University. We are looking forward to doing more collaborative activities in research and education. To all participants, thank you for joining, and I hope you enjoy this event. I believe that during this international guest lecture, we have had a fruitful discussion regarding the current management of thyroid nodule. We have learned a lot from the speakers about the emerging role of radiofrequency ablation in this disease, especially during pandemic. I'm hoping that this knowledge will help us improve the way we treat our patients. Finally, I would like to thank all the committee members for organizing this event. I know that they have been working with enthusiasm to make it all such a success. We couldn't possibly hold this event without the support of Dr. Yarsa and team from General Surgery Division, the tremendous effort from staff at Radiology Department, and of course, all members of research group Brain Degenerative Disease and Cancer. I know this research group is one of the signing research group in Faculty of Medicine, Universitas 11 Maret, because it has so many good activities in research and community service. Great job, team. And let's have a nice weekend, everyone, and hope to see you in our next event. Assalamualaikum warahmatullahi wabarakatuh. And I will give the time back to the Master of Ceremony. Thank you.
Thank you, Dr. Eti, for the speech.
Now we've arrived to the end. Well, talking about an end seems always so sad though, but we sincerely hope that all of the attendees and all of us have grasped like new insights and learnings from today's lecture, and of course, eagerly waiting for many more lectures to come.
Absolutely. So we would like to say thank you for all the participants, for amazing speaker as well, and all the honorable attendees as well. And we hope we can see you again on next webinar.
Oh, and not forget that we want to apologize for the inconvenience that we've met during this webinar. And see you again on the next webinar.
Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Professor. Thank you.
Thank you. Thank you.
Thank you, Prof.
Bye. See you.
Kamsahamnida, Jasmine.